Good afternoon. My name is Anna Johnson with the National Center for Youth Law, and I'm here presenting today as a panelist with policy researcher Nathan Camps Hughes. I'll introduce Nathan and then hand over the beginning of the session to him. Nathan is a graduate student who is a concurrent Master of Public Health and Master of Social Welfare at UC Berkeley and will be graduating this May. Much of Nathan's academic and professional work has been centered around the intersection between mental health and physical health, with a developing focus on appropriate treatment for children and youth who have experienced traumatic events. Today's presentation is informed by the increasing interest and attention from state-level policymakers in regards to the foster youth over-medication problem. Nathan has worked with the National Center for Youth Law as a policy researcher, with his work focusing on how to best address this complex and growing public health problem. Nathan conducted interviews with foster youth advocates, Department of Public Health employees, psychiatrists, external quality review organization staff from various states to highlight the various approaches that have been taken to address this issue. It is our hope that you will leave today's discussion better equipped to develop policy and legislative initiatives that have the best chance of being accepted and adopted in the counties and states where you work. We have representatives from across the country listening in, and we'll start by introducing some of the main issues that have been found nationally from Government Accountability Office reports, local studies, and different state initiatives have led for the general consensus to be that too many psychotropic medications are being prescribed at too high of doses at very young ages for too long. And here we have a quote from one of our former foster youth who experienced being on 6 medications, 12 different pills, 6 in the morning and 6 at night, who experienced pretty severe side effects from these medications and has gone on to advocate for improvements in safety and in ways to support youth who have learned and dealt with traumatic experiences, difficult experiences in the foster youth system, and have survived to tell their stories and are out there requesting for significant improvements. With that, just our intro, I'll hand it over to Nathan to begin his portion of today's session.
It is my hope that you will leave today's discussion better equipped to develop policy and/or legislative initiatives that have the best chance of being effective, but perhaps of equal importance, being accepted and adopted in the counties and states where you work. This slide just gives you an indication of our overall ethos. This is a quote here from one of our former foster youth who's currently an active member of our legislative advocacy team. It highlights a not unfamiliar story around just the prevalence of psychotropic medication administration amongst foster youth. So the national prevalence of this problem is concerning. The rates at which foster children are being prescribed psychotropics is substantially higher than those among non-foster youth. At the federal level, the rates are between 3 and 4.5 times higher than non-foster youth. And here in California, nearly 25% of youth in foster care are receiving psychotropics, which is 3.5 times higher than non-foster youth. Some of this disparity may be explained by foster children's greater mental health needs, lack of coordinated medical and mental health care, and limited oversight of prescribing practices. However, we maintain that these systemic flaws and social disparities in health do not justify the potential risks associated with these prescribing practices. For example, not only are the prescription rates among foster youth much higher than among the youth outside the system, but we are also starting foster children on psychotropics at much younger ages. In California alone, nearly 300 children under the age of 5 are prescribed psychotropics annually. And while this number may not seem like much, any prescriptions among this age group should be cause for concern. Why is this? The bottom line is that these drugs have not received FDA approval for therapeutic use in this population, nor have any empirical studies or randomized controlled trials been conducted amongst this age group, which means that there's really no data that establishes the efficacy of psychotropics among young children, nor is there any data about the long-term effects of such medications, nor an adequate understanding of the potential impact that these drugs may have on developing brains. It's these legitimate concerns that have led many states to actively discourage such prescribing practices. But nonetheless, these recommendations do not prevent such prescriptions from being administered to some of the most high-risk children. And the types of behavioral problems that manifest in young children for which such medications are prescribed are often the result of traumatic experiences that place them in foster care in the first place. As a result, the pharma-first approach to treatment may not provide the therapeutic benefit that we hope for. The problem of over-medication with psychotropics is also more heavily concentrated in certain placement settings. In group homes in California, more than 50% of the nearly 4,000 foster children in the California group home system are receiving psychotropics, with particularly high rates up to 100% in some of the smaller counties. There's certainly those who suggest that these high rates are justified by the high level of behavioral health problems experienced by foster youth in these settings, but arguments in favor of these prescription trends often suggest that for many kids, psychotropic medication is the only thing keeping them from being kicked out of group homes and transferred to a higher level of care, which in this case would be juvenile detention facilities. But this does beg the question, what percentage of these prescriptions are for behavioral control or to make these kids more manageable in these settings, and how much are actually helping the mental health conditions for which their prescription is being justified. As you likely know, 50% of foster children on psychotropics in California are receiving the most dangerous class of drugs, which is antipsychotics. And data reviewed by the San Jose Mercury News indicates that among the thousands of foster children placed on psychotropics over the past decade, nearly 60% were given an antipsychotic. This class of drugs is only FDA authorized for severe mental illness, like schizophrenia, bipolar disorder, and some forms of autism, but nonetheless, they're often being prescribed for what might be labeled euphemistically behavioral problems. Because do we really think that 50% of foster youth on medications have a severe mental illness? That would mean that approximately 12.5% of foster youth in California would have either schizophrenia, bipolar disorder, or severe autism. 12.5%. But the lifetime prevalence of these conditions is significantly lower. For instance, schizophrenia lifetime prevalence is 1%, with a mean age of onset of 18 years old in men and 25 years old in women. So perhaps the concentration of schizophrenia is simply much higher among the foster youth population. The prevalence of bipolar disorder is similar. The average age of onset for bipolar disorder is in the early 20s for men and women, with a lifetime prevalence of 0.8% for bipolar 1 and 1.1% for bipolar 2. But again, perhaps the prevalence of this condition is also much more heavily concentrated among foster youth. And the third condition for which the FDA has approved the use of antipsychotics is severe autism. The prevalence of autism in the United States is estimated at 1 in 68 births, which would be 0.015%, quite small. So all this leads us to believe that even if the prevalence of these mental health conditions among foster youth is slightly higher than among non-foster youth, there's no data that suggests they are significantly enough higher to justify the current rates of antipsychotic administration.
And this is Anna Johnson from the National Center for Youth Law, and I just want to give an update for the attendees. Almost everyone is now logged on that I think is going to join us today. We have attendees from on a national scale on the line today, and we're hoping that folks will write in questions into the chat function, and we can answer those throughout the presentation. Nathan is giving his initial review of his research and work that he has done on reviewing the use of psychotropic medications with children in foster care and some of the strategies that states have used over time to improve the safety in the practice. So we have attendees from various states and from the national scope as well. And we have also members of the different California counties on the line today. So we've got a pretty diverse audience, and hope to hear from you all as we continue our presentation. Thank you.
So let's talk a little bit about the financial and human costs of this public health problem. From a strictly health perspective, We know that many of these psychotropics carry significant side effects and some potential chronic physical disabilities resulting from long-term psychotropic administration. Obviously, amongst all psychotropics, antipsychotics have the most dangerous side effect profile, and which is not insignificant given the extent to which these drugs in this class are being prescribed. As you may know, antipsychotics do have quite an extensive, potentially dangerous side effect profile that include, but are not limited to, irreversible movement disorders, also known as tardive dyskinesia, seizures, increased risk of diabetes, increased risk of cardiovascular disease-related complications, kidney and liver damage, metabolic disruption resulting in rapid weight gain, all of which can add up to chronic physical disabilities resulting from their long-term use. Turning to the financial burden of these prescription rates, California spends more on psychotropics for foster youth than on any other kind of medication among this population. An analysis of Medi-Cal spending on the most costly drugs being prescribed to foster children revealed some additional facts. Over the past 10 years, California has paid more than $226 million on psychotropics for foster children. And this amounted to 72% of the total spent on the 10 most costly groups of drugs prescribed to foster youth. In terms of the financial cost of treatment of long-term psychotropic-related disabilities, unfortunately, little is known about the precise costs associated with this. Much of this gap in knowledge is due to the fact that few longitudinal studies have been conducted with this population. But nonetheless, this financial figure is likely to be large, just given the side effect risk of antipsychotics and its relationship to increased risk of diabetes and heart disease. From the American Diabetes Association, people diagnosed with diabetes incur average medical expenditures of approximately $14,000 per year, of which about $8,000 is attributable to the diabetes. And people with diabetes on average have medical expenditures approximately 2.3 times higher than what the expenditures would be in the absence of this disease. And according to the American Heart Association, a person with heart disease is burdened by enormous medical expenses, including diagnostic tests, surgery, hospital and doctor's visits, physical therapy, and costly medications. A conservative estimate of these costs for one person is $121,000 over 20 years. But those needing surgery or specialized medical procedures and ongoing care, the cost for them can be up to $5 million over a lifetime. The question that we have is whether these potential long-term costs associated with psychotropic administration and antipsychotic administration are being considered when decisions around the maintenance of current prescribing practices are being made. So we'd like to now discuss some of the findings of our research over the summer and this fall. Our analysis has revealed several domains, those that you see before you, in which states are working to address this problem, with enhanced data collection processes being among the most widespread. It is our belief that in the absence of reliable and consistent information on psychotropic prescription trends, and the extent to which foster children are receiving other first-line psychosocial interventions, our ability to quantify the potential overuse of medication and to appropriately allocate resources to address this problem, or to measure the effects of policy change, is limited. And our analysis also revealed several common data points currently being collected across various states. There's considerable overlap across states in terms of what data is being collected, but this chart presents some of the more common indicators that are being collected. It's obviously important to know the number of youth in care who are receiving psych meds, so we can track changes over time from year to year. Polypharmacy measures are also very common and important, just to know how many different drugs a given child is receiving. Then do those align or do they not align with the DSM diagnosis in their medical chart? Measures of co-pharmacy, how many children are receiving more than one drug in the same class? And again, is there a corresponding justification for this second drug in the child's medical chart? Metabolic monitoring measures are also very important, particularly when prescribing antipsychotics, such as blood glucose levels, body mass index, weight fluctuations over time, which can all indicate higher risk for other conditions such as diabetes, cardiovascular disease. It's also important to know dosage rates. Are they within parameters established by the FDA or other medical authorities? We want to know prescription rates by age group. And we want to know the extent to which non-pharma psychosocial first-line interventions are being provided. Are they being made available? Are they evidence-based? We think it's also important to know the rates of emergency medication administration. How frequently are counties and or group homes prescribing emergency meds beyond established care plans? Are these being justified? And finally, it's very important to understand whether the drug is indicated based on a DSM diagnosis, which would allow us to know what percentage of these drugs are being prescribed off-label. If you'd like a more detailed list of our data collection recommendations, in the documents that we've attached to this webinar, you will see the appendices from a policy brief that we recently released. And Appendix D provides our complete list of data points that we recommend being collected. So continuing with different approaches taken by states to address this problem, moving to prior authorization processes. Various states are currently using prior authorization processes to add an additional layer of protection against children's receipt of potentially dangerous prescriptions. Such policies can prevent the filing of prescriptions at the pharmacy level for certain medications, dosages, combinations, or age ranges, and which can help to ensure that prescriptions that children receive are appropriate, again, for their mental health diagnosis, their age, and their weight. The majority of states have used this strategy to target antipsychotics among children under 6, given the high risk of side effects and questionable therapeutic value of this drug class for young children. But nonetheless, the potential here does go beyond that age range or this drug class. For instance, Maine has implemented restrictions at the pharmacy point of sale, disallowing the filing of certain prescriptions without prior authorization based on dosage, co-pharmacy measures, and potentially adverse drug interactions. Other states, notably Illinois and Michigan, have broadened the use of prior authorizations to prevent the use of psychotropic prescriptions among foster youth as a method of discipline or behavioral control, or a substitute for less risky psychosocial interventions, or in cases where the prescribed drug is not consistent with the patient's diagnosis or target symptoms. Washington State requires a second opinion prior to the administration of a psychotropic medication under various conditions, including, but not limited to, the absence of a DSM diagnosis in the child's claim record, psychotropic medications prescribed to children under 5 years old, and also for prescriptions exceeding dosage limits for age based on established parameters. Here in California, in 2014, the treatment authorization request process was implemented as a requirement for all antipsychotic prescriptions. And each treatment authorization request must be approved by a third party before the prescription can be filled, which adds an additional layer of oversight for this drug class. Second opinion and specialist consultation processes have also been very useful. In the best principles guidelines published by the American Association of Child and Adolescent Psychiatrists, they recommend that all state and county child welfare agencies empowered by law to consent on behalf of children for treatment with psychotropics should design a consultation program administered by child and adolescent psychiatrists. Such symptoms have been implemented across several states, allowing for prescribers and consent providers to query expert opinion prior to making treatment decisions. In Massachusetts, primary care physicians who treat children have access to the Massachusetts Child Psychiatry Project, allowing pediatricians rapid access to child psychiatrist consultants and also available to primary care physicians at no cost. In Michigan, consultations are automatically provided to prescribers based on established triggers, such as a child on 4 or more medications, or a child under 5 years old on any psychotropic medication. Other models allow for consultation prior to providing consent, such as the case in Oregon, where child welfare agency officials have access to child psychiatrist consultants before making consent decisions. Finally, the state of Washington has taken a comprehensive approach, providing both a telephone consultation line for pediatric providers as well as a partnership between state Medicaid and medical centers to conduct second opinions via record reviews. Provider outreach, feedback, and education strategies have also been used. Most states have opted for an education-based strategy, focusing outreach on those providers whose prescribing patterns fall outside of established guidelines. In Alabama, the state provides a focused mailing to prescribers of any antipsychotics to children under age of 18, as well as a telephone outreach by child psychiatrists to prescribers of antipsychotics to children under age 5. Colorado sends educational alerts and letters to prescribers detailing information about the psychiatric medication utilization of their patients. And if post-intervention changes are not observed, the state sends follow-up letters and or sets up face-to-face meetings with peer consultants. In Illinois, they maintain a watch list of high-risk prescribers, and utilizing this data to assess the impact of changes in consent policies on prescriber behaviors. Michigan created a system where child psychiatrists are able to follow up with prescribing physicians when indicated based on state-established triggers, and during which cases are reviewed and providers are given consultation. Finally, Missouri uses the behavioral pharmacy management system to analyze prescribing patterns for children and adolescents and send letters to prescribers offering consultation on best prescribing practices. These are all varying strategies states have taken and to the use of provider outreach, feedback, and education. Minimal on the corrective action side, but anecdotally, those that we interviewed indicated that the vast majority of prescribers that were identified as being sort of outside of the norm were really appreciative of this level of feedback and demonstrated changes in their practices after the intervention. And finally, moving to one of the perhaps most important and most difficult of the interventions that states have used to address the overmedication problem is the enhancement of psychosocial interventions. And the inaccessibility of evidence-based psychosocial interventions is frequently cited as an explanatory factor for the increasing reliance on pharma therapies for children with behavioral health problems. Many of the key stakeholders we interviewed lamented the limited availability of psychosocial services in their respective states and regions, and suggested that providers in their areas would prefer to initiate such services prior to administering psychotropics if they had the option. It is likely that many of these non-pharma interventions might be the most effective means to addressing the underlying mental health needs of foster children, but effecting this change is complex and might require a shift from a crisis management approach to behavioral health towards a more prevention-focused approach. And obviously, expanding the array of evidence-based psychotherapies available to foster children is dependent on the availability of mental health funding and collaboration between counties and state agencies to develop a more prevention-based approach to mental health treatment. Here at Nickel, we currently have research teams investigating the various funding streams available for foster youth mental health services in California, and we are also looking into prevention and the expansion of access to psychosocial interventions for children whose mental health conditions are considered mild to moderate. So what does all this mean? Do we know whether it has been successful? Our findings thus far indicate that these interventions can help to reduce the overprescription of psychotropics amongst foster youth. Perhaps unsurprisingly, data collection-based interventions have shown the most success. And as you can see, New York experienced a 25% reduction in antipsychotic polypharmacy, which they attribute to their data collection and dissemination processes. Ohio has demonstrated a similar 25% reduction in antipsychotic prescriptions to children under 6, as well as antipsychotic co-pharmacy and psychotropic polypharmacy. Illinois has indicated decreasing trends amongst various high-risk prescribing practices, which they attribute to their data collection processes. And if you recall from one of the previous slides, their data collection system is one of the more robust. Vermont has also seen a decline in the prescription of antipsychotics to children, as well as the percentage of psych meds being prescribed by non-psychiatrist MDs. And so again, without having access to the data, without collecting and sharing the data, there's really no way to see what successes are taking place. We've also seen successes, it's not here on the slide, but with the use of prior authorization. Since California here initiated the treatment authorization request process in 2014, approximately 30% of these requests have been rejected upon first submission for lack of supporting documentation or because of duplicate requests, thus helping to ensure that these prescriptions are justified and appropriate. Over the first year of implementation of the TAR process, California observed a significant reduction in the number of requests for antipsychotic administration approval, corresponding reduction in pharmacy claims for these drugs. In terms of second opinion, specialist consultation, the state of Washington has seen a 53% reduction in high-dose prescriptions, a 23% reduction in psychotropic prescriptions among children under 5, which amount to roughly an annual savings of $1.2 million. So what are our recommendations? Primarily to develop a thorough data collection, analysis, and dissemination process, and to use this data that we gather to inform provider outreach and education programs, as well as triggers for specialist consultation and second opinions. With this approach informed by the questions that you can see: who are the prescribers? Are they pediatricians? Are they child and adolescent psychiatrists? How do we identify who may be prescribing outside of their area of specialization or expertise? And what resources can we provide to assist them in prescribing more appropriately? Based on what we've seen work in other states, again, we do recommend enhanced data collection processes and using this as a way to inform some of the other interventions that we've discussed, with the caveat that it's important to develop interventions that are not exclusively focused on a narrow subset of providers who may be overprescribing. By making these services available to all practitioners who prescribe to foster youth, states can ensure that provider support mechanisms are not restricted to those who may be prescribing inappropriately. And we also believe that providers are less likely to push back against legislative or policy change when the interventions are not perceived as punitive. I'm going to pass the mic over to Anna Johnson, policy analyst here at the National Center for Youth Law, to describe the efforts by NICL and here in the state of California to address this problem.
Okay, thank you, Nathan, and thanks everybody on the webinar today. I'm hoping that folks can send in any questions, type in any questions that they have for Nathan or for me as I'm speaking through this today. based on all of the research and findings from various states, here in California, the National Center for Youth Law has tried to take some of those best practices, mature practices that from other programs and from some of our counties that have implemented some of these strategies individually for some years now here in state. Since 2012, I have been a member of our state work groups that are the clinical work group, which established a set of guidelines for California. That group did use a collection of information from various state guidelines and some internal experts and child and adolescent psychiatrists and pharmacists to come up with those parameters, as well as many of our clinicians and folks that do the trauma-informed interventions, and to connect between what is the pharmacy practice and what is the therapeutic intervention on the ground. So those are now available from our state. We also have the data and technology work group. With that work group, we were able to develop 6 measures that the Department of Healthcare Services and the Department of Social Services have been working on together to share the information about the children who are in foster care and match that with the pharmacy claims themselves and what are the actual medications children are picking up and receiving. And finally, the Youth Family Education Work Group has developed a few documents, one being a Foster Youth Mental Health Bill of Rights. That is now available online and is becoming a brochure that will be disseminated to foster youth statewide. That also includes questions to ask. So if you're a foster youth that is considering psychotropic medications, what should you ask your doctor? What should you ask the pharmacist? What does your caregiver need to ask? What does your advocate need to ask for you? And those are now available. So our first approach was to work within the existing efforts of the state, which was our state work groups. Then, based upon our efforts at the state, we decided to put together a legislative package using some of the research and some of our senators who were championing this issue last year. I'll talk about some of those bills and what they mean, but here you can see our legislative package from 2015 included 4 bills that focused on the child welfare side of improving safety and practice in the prescription of psychotropic medications. And then this year we're working on 2 bills that follow up more on the healthcare side of oversight of mental health services and the individuals who do the prescribing. So I'll now show you just a summary of our bill package from last year. So one of our bills discussed the data and training that would be necessary for caregivers, social workers, attorneys, judges, and for youth to really understand what these medications are for and what are their benefits and what are their risks. And also, when is it in the best interest of the child to try a medication, psychotropic medication, and what sort of supports need to be in place in order for that to be as safe as possible. So that bill was signed, and our data and training is now underway with support from the Judicial Council of California, the Department of Social Services and Healthcare Services, and advocates around the state, as well as counties that are implementing and signing on to a data sharing agreement. We have a bill around foster care public health nurses. Now, this is a federal program with a 75% federal fund match to states that use foster care public health nurses to update youth medical records and to advocate on behalf of the child's needed screenings, health screenings, appointments, monitoring visits, follow-up, any sort of review of those treatments, and to work with the providers and to work with the social workers. And public health nurses, we believe, are a great asset and think it's a great solution for all states given the 75% federal match of funds for those positions. Our final bill that was signed last year is a group home oversight bill. And essentially here we're using data from the Department of Healthcare Services with the Department of Social Services to identify group homes that may be over-reliant on psychotropic medications, particularly with the concern of behavioral control rather than for a medically accepted indicator. essentially, this is now in implementation phase, and we'll be able to see how that goes after this first year. We are working with stakeholders to develop that methodology so that group homes that are serving foster youth with higher needs aren't necessarily compared to youth that are being served at the lower needs. And then finally, we had a bill that would improve our court processes and do what Nathan was speaking of earlier, which is to allow for the second opinions or second consultation to be available for the prescription of 3 or more psychotropic medications, prescriptions of psychotropics for children 0 to 5, or for 2 or more antipsychotics. So some of those most extreme prescribing practices that can have significantly higher health risks. So we did look into that. We're still working on finalizing that bill and moving it to the governor's desk shortly. Some of our follow-up from our package last year involves taking a look at the prescribing practitioners themselves. Now, what our goal here is to do is to gather state data and to share it with the Medical Board of California. That would look for the most extreme outliers of the prescribing field. So folks that are sort of continuously, excessively prescribing 3 or 4 psychotropic medications long-term for more than 90 days. Certain triggers like that have been identified as severely risky to physical health of a child. So we're looking into that with a bill this year, SB 1174. We are also following up with one of the most important of the interventions, which is increasing the use of evidence-based therapies for children in foster care. We're working with Senator Bell again on SB 1291. That will look for counties to send a foster care mental health plan to the state for review to make sure that foster youth are being provided the appropriate services as a first line of treatment or as conjunctive with pharmacology. So again, this lays out all of the bills that we've been working on here with the different legislative champions, and I'm happy to answer any questions that you have about those. And here on our website, we have all of the additional resources about the brief that was submitted, about this webinar, a lot of our research, any information about our bills you can find on this website. And now I'm just going to see if anyone has any questions or comments regarding the webinar, and I'll look to the chat function for that. So one question that did come in asks, how do other states fund a second opinion psychiatrist? And what I'll say about that is that some states do actually have legislation and a budget item that funds a position, such as Washington. Some of that money is recouped through Medi-Cal spending. Others use Medi-Cal or Mental Health Services Act funding in California and some of our counties, or a combination of funds. Up to, I believe, 4 hours of face-to-face second opinions are billable to Medi-Cal. Beyond that, there's other funds needed, but the majority of these costs, especially for a paper review or a telephone consult that doesn't take longer than 4 hours, can happen and be reimbursed with existing funds. Another question that we did receive asks, within all of these state sites, is there any data coming forward to track the lack of positive outcomes that can be associated? And I think the rest of the question got cut off, but I'll try and read into that a little bit in saying that are associated with the positive outcomes of using the psychotropic medications. To my knowledge, there are some states that are working on developing outcome measures and systems. Here in California, we're just now beginning to talk about what a more holistic approach and tracking long-term outcomes would be. Most of the research right now does not track long-term outcomes for youth, although in the Mark Courtney study done around ACEs, the adverse childhood experiences, and others, there is some more longitudinal data available, and so I would direct people there. A lot of the long-term data and research is not conducted. As we know, most of these drugs are tested in adult populations and for short-term trial studies of a few weeks and usually no longer than a month and a half. So there really isn't available data to my knowledge. And if others on the call or that listen to this webinar do have that information, please do let us know and we'll be happy to share that out. And one final thing that I'll answer that question with would be to listen to the webinar that's happening on March 24th by the California Evidence-Based Clearinghouse. They'll talk about some of the strategies and evidence-based therapeutic services that should be made available in advance of trying pharmacology or in conjunction with psychotropic medications for treatment for children in foster care. So no one has any questions, and I hope that this information has been helpful and that you've been provided with our links and materials from this webinar. We'll be sending the recording out if people want to listen to that again, or if you have follow-up questions, you can see that my email is here, my phone number. Please call or email with questions or comments if you're working on things in your own state or would like to send information to this group about initiatives that are underway in your county or in your state. We'd love to hear about them and welcome your participation there as well. So thank you so much, and we'll be closing out the webinar if there are no final questions. Thanks everybody, and have a good day.